I would like to welcome everyone to today's webinar, Connecting to Care, Promoting Compassion Through Staff Self-Discovery and Engagement. I'm Andrea Greenberg, Communications and Partnerships Associate at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. As you exit the webinar, you will receive an electronic survey that we ask that you take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, and thank you, Andrea. Good afternoon. Thanks to all of you for joining us for our 2017 webinar series on Compassionate Collaborative Care, or what we're calling the Triple C. Our Compassionate Collaborative Care framework explains some of the key values and skills that help us offer compassionate collaborative care to patients, families, colleagues, and coworkers, while also sustaining ourselves and our sense of meaning at work. This framework is available to you on our website. This year, the Schwartz Center's webinar series will focus on creating organizational cultures of compassion and collaboration. This is also the focus of our inaugural annual Compassion in Action Healthcare Conference in Boston, June 25 through June 27 this year, 2017. Today's webinar speaker, Dr. Harris Baden, will be one of many dynamic and innovative presenters at this conference, so please visit our website and register to attend. So now let me introduce today's session, Connecting to Care, Promoting Compassion Through Staff Self-Discovery and Engagement. During this section, Dr. Baden will describe one academic pediatric medical center's efforts to enhance the experience of care for patients and families by enriching the experience of care for staff. The journey includes the initial program developed by doctors for doctors to optimize connection with patients and families that then evolved into an institution-wide effort to promote and support a culture of compassion for patients, family, and staff. Through a process called Facilitated Self-Discovery, Dr. Baden and his team have worked to promote presence and empathy in all interactions with a belief that this increases fulfillment and resiliency and thereby mitigates burnout. The process requires genuine commitment from the hospital leadership that integrates well with their existing commitments to family-centered care, continuous improvement, safety, and staff well-being. So today we are honored to have as our speaker Dr. Harris Baden, who is the Professor and Chief of Pediatric Cardiac Critical Care at Seattle Children's and the University of Washington School of Medicine. Welcome, Dr. Baden. I'll now turn the program over to you.
Dr. Baden, we need you to unmute.
I was off to such a good start. Thank you very much. I am thrilled to be able to share our experience from Seattle Children's. I want to be candid in saying we're really in many ways making this work up as we go. And so along the way, we've learned a number of lessons. And so also at the end, I will be eager to receive feedback from those of you in the audience who I'm sure have been on similar journeys. Our objectives for today are to recognize the value of focusing on staff satisfaction and well-being to promote a culture of compassion in your organization, and to understand the importance of engaging staff through facilitated self-discovery to develop effective and sustainable strategies and solutions. a little bit about who we are at Seattle Children's. Actually, as is I'm sure the case for most of your organizations, we're rapidly growing. And so when this slide was made, we had 311 beds. We now have 371 beds just in the last 6 months. We have, it looks like in Europe, I guess, 5.17 employees, but I think that actually means we have 5,170 employees. And we have over 1,300 active medical staff. We have some unique aspects of the care that we deliver. We are the only freestanding academic pediatric children's hospital for Washington, Alaska, Montana, Wyoming, and Idaho, which represents 23% of the United States land mass. We're not a densely populated area, but what it means is that our patients come from great distances and in many cases are dislocated, if you will, from their families as well as their typical support systems. That creates I believe, opportunity and obligation for us to be attentive to their needs in ways that are all-encompassing. So as Dr. Lone shared, I am a pediatric cardiac intensive care specialist. I've been in this field for over 20 years. And that means I take care of children who are critically ill with complex congenital heart disease. Recently, I had the opportunity to admit a baby to our intensive care unit in the middle of the night after being delivered at the University of Washington. This particular baby, like many of ours, had a prenatal diagnosis of complex congenital heart disease. And after stabilizing the baby in the intensive care unit, I then spoke with his father at the bedside. And after orienting him to what was going to happen overnight and what the plans would be for a surgery that his son was going to need in the coming days, I asked him a question that I ask all parents, and that was, is there anything that I can do for you? And his response was, just promise me that you will bring your best self every day. And to me, that was a very powerful comment. I think in many ways it encapsulates the work that we've been doing. And I think if you look closely at the question, it's filled with, I think, lots of answers and directions for us to focus our work. On the parent side, I think it reflects the fact that the parents and patients in many cases are overwhelmed, that they're probably scared, and at a minimum that they feel vulnerable in this environment that is unusual for them and intimidating and obviously fraught with the concerns about their child's condition. In many ways, I took his comment to suggest that what he was looking for was a steadying hand to someone to help him through this process. But equally interesting to me was a consideration as, well, what does that mean to me as a provider? And what does that mean to the providers and the other staff who I work with every day in the intensive care unit? What do I need to be my best self, to bring my best self every day? What does that require of me? What does that require of the team that I work with so that we're supporting each other in a way that we can be our best as individuals and collectively? And then what does it mean for our organization? How do we support our staff in a way that they're able to bring their best selves and meet the needs of the patients and families that we serve? So as a little bit of history, several years ago, I endeavored with the help of others here to create a program. And really the goal of that program initially was to think about how could we as physicians promote a culture of service to the patients and families we serve. And we, I think, were somewhat prescient in recognizing very early on that the family experience, the way I describe it in our Connect Vision slide that now is many years old, was the family in the lower corner saying, we wouldn't want to go anywhere else for our child's care. And in turn, a provider with his hands in the air saying, I wouldn't want to work anywhere else. And if we can create an environment where our providers and the other staff come to work with that sense of purpose and fulfillment, then I think our patients and families will benefit. So that was one of our operating principles from the very beginning. Now it also, I think, alludes to a very delicate balance that exists Really what we're talking about is a relationship here, in this case the relationship of a family who's in a tense situation and the providers that they're depending on to help them through that journey. Like any relationship, the needs of both parties need to be understood and met. We were attentive enough to the staff, and I think the question has become over time, and this is one of our lessons, were we attentive enough to the staff experience? So we were doing things clearly with an emphasis on raising the experience of the patients and families we were privileged to serve. But in doing so, were we increasing inadvertently the burden on the patient, on the providers and the staff that we worked for? And at worst, were we adding to the burden of an already stretched or burned out group or individuals? I'll get back to that later as we start to think about as I start to describe how our program evolved. So as we endeavor to create this program for our physician staff, the first, I think, very important step that we took was that we surveyed our faculty. And basically we asked them, and this is a group of over 600 and including the community docs, over 1,300 providers who are academic physicians who have chosen to be in the realm of advancing not only the practice but the science of the care that they deliver. And with very fortunately, and as I was very much hoping, when asked to rate in order of importance what were the factors that contributed to their job satisfaction, the relationships with the patients and families that they work with every day came out on top. And so that was very powerful, because that then meant that we had something that was meaningful to the providers, and that's something that we could then leverage. So with that knowledge, we tried very intentionally to tap into their innate motivations by appealing to their hearts and minds. This is a part of our program that I think we were extremely committed to, and in many ways extremely successful, and I think is one of the things perhaps that distinguished our effort, not only from efforts at other institutions to endeavor to improve the experience of patients and families, but any really endeavor, quality improvement exercise in an organization. We really wanted to leverage that understanding that this work was important to providers, and we saw that as a way to engage their hearts and minds in a way that ideally we would reach a point where they would raise their hands and say to us, what can I do to improve the patient and family experience, and ideally my own? And so we set out to inform them and ultimately to empower them. And when I talk about informing them, it was really to look at the data that was already available. We obviously have lots of information that tells us what the experience of the patients and families in our organization is, but also then to personalize it in a way by developing a couple of tools that we asked them, one, a self-assessment, that asked them questions about how they engage with patients and families that we hope would be revealing to them, but also somewhat insidiously start to teach them that, oh, well, maybe it's important that I sit down when I talk to a family member and I look them in the eyes and I start to convey to them that I'm truly present. And then we deployed what was essentially a 360 survey to the areas where they work. So in the example of my team in the intensive care unit, I sent out on behalf, if you will, of the faculty in my section, a 360 to the nurses who work with us on the front lines, the pharmacists, the therapists, to ask them a series of questions about each provider and how they were viewed, how they viewed them in terms of their interactions with patients and families and with staff. And then with that information, we tried to develop an educational program that could help providers in understanding where their opportunities for improvement were and in understanding what were best practices as we stole from other organizations around the country, and we used our own experience and research to inform what we believed to be important qualities and elements of the interactions we were striving for. And then we developed workshops to bring the doctors in, and very importantly to us, not script what we wanted them to say, but to, through this process of self-discovery, which I'll describe in a moment, have them help us articulate what were the elements of an interaction with patients and families that would probably convey to them the feeling of caring that we hoped, and also the development of trust that we think is so important. We also developed some adjunctive aspects to our program, like one-on-one coaching and consultation to groups. We applied for, I think very importantly, we applied for accreditation as a maintenance of certification program for our physicians, so that served as a carrot, if you will, for their participation. But also for us, it gave us a structure that helped ensure that the work that we were doing was not just a one-time encounter, but required some ongoing interactions that we hope contribute to sustainment. And then, because we're an academic center, we applied for some IRB approval for studies so that we could look critically at the work that we were doing and understand if, in fact, we were making an impact, and then try to then dive a little deeper and understand what were the best practices that were compelling to the providers, as well as in turn effective in enhancing their interactions with the patients and families. We also were extremely open to providers who endeavored to work with us to say, if you want to join this effort, it's non-proprietary. If you want to study, if you want to create study protocols that help you understand in your area or contribute to our bigger efforts, then we welcome that opportunity. So again, in many ways, another carrot. I include this slide. It's a reference to, I think, one of the most important things that we did, and certainly one of the most powerful, and that was we created a video. And in this video, called Lessons from the Other Side of the Bed When the Doctor's Child is Sick, several of our staff, of our physicians, share very generously their experiences as parents of children who receive care at our hospital. And I can tell you, I don't think that there's anything that we've done that's been more powerful in terms of grounding the audience in what the work is, and in understanding what it is that we're striving for and what the opportunities are, and in also breaking down what I think is a natural wall that many of us build up. I know when I come home at night and I talk to my wife about one or two of the things that I've dealt with during the day, my wife instinctively always asks questions about them that in somehow, I think in her mind, and we all do this, differentiates that family from us, so that the fear that this could not happen to us is something that makes it sustainable. But this video was very powerful in breaking down that sense of other, and recognizing that these are our colleagues, our parents just like us, and the experiences that they're having could easily be us, and that their insights are incredibly important to informing the work that we've done. So after we, after we created the video and built, I think, a tremendous amount of enthusiasm for the work, we then started to craft these workshops and to deliver these workshops for our staff. And if you follow the circle around, I would say that self-discovery at 2 o'clock is an important and something aspect of the approach, and something that we don't waver from. We do not come into these workshops and ask or, if you will, lecture in a didactic manner to the staff about here's what's important for patients and families, and here's what we need you to do. Rather, we share that video, we show that video, we debrief that video, we ask them to think about and share their own experiences as patients or as consumers of healthcare for parents or their own children, and also just their own insights that they've gained from being on the physician side of the bed. And then in that exercise, we look for the key words and the key elements that we know are important to moving our curriculum along. And so when they describe a scenario or overtly use the term empathy, then we sort of write that down on the board and we say, empathy, let's talk a little more about what empathy is. Because we believe that making that connection in an empathic way is what can help us then lead to the next sort of manifestation of this, which is how do we genuinely have compassion in the work that we do for the patients and families we serve. We also think that the circle continues in that if the providers engage in that genuine way where they are understanding and putting themselves in the shoes of the patients and families, and then helping us develop a curriculum to meet the needs that they describe that they think these patients and families probably want, that also brings greater meaning to them. It's a drug that as you do it and you get that positive feedback, it becomes something that feeds those of us who are in this field who hopefully invariably are here initially at least because of our desire to serve others. And that, we believe, is an important sustainment strategy. So within the workshops, we talk about the importance of building trust with patients and families. We talk about the fact that the care that we provide, the picking the right antibiotic or making the right diagnosis, is something that to our patients and families is a given. They assume that we're going to do that. The thing that distinguishes whether they leave your office that day or whether they leave the clinic or the inpatient setting or the operating theater or wherever you may encounter them, the thing that to them is most important in determining whether you're a doctor that they would recommend to others is this question of whether you conveyed to them that you genuinely care about them, beyond your technical expertise and your intellectual capacities, that you actually convey to them that you get it and that you understand where they are and that you convey that you care. And we believe that in creating that sense of trust and that caring interaction, that truly is compassion, and that enhances the experience for both the provider and the patients. So the good news is that we were really successful. When we started rolling these workshops out to the providers, the feedback was overwhelmingly positive. And I say that with an understanding, someone who's long been involved in quality improvement exercises in an organization. And this may come as a secret to some of you, but probably to most of you not. Doctors reflexively recoil from administrators who come in with good ideas to help them improve the quality of the care that they're delivering. And so the fact that we were able to get beyond that and to actually get feedback from them that said, hey, I see this improving my ability to connect with the patients and families that I'm serving, and that I see it as in some ways contributing and hopefully in a very meaningful way to my own job satisfaction, was very affirming to us. Likewise, we got a lot of comments. We have hundreds and hundreds of comments from providers. These are a few that are, I believe, honestly representative, acknowledging the art and skill and humanity of our interactions, making me feel better as a doctor. I wish I could have done this work years ago, and one of my favorites was someone who stood up and said, I've worked at Children's for 35 years and I've never been more proud of this institution than I am right now. It really just helped us to understand that we were on the right track and we were providing something that our providers wanted, and we knew that our patients and families would benefit from. So with the attention that we were gaining within our organization and frankly external to our organization, there became this question of how can we bring this to others. In fact, we started to get accused of being exclusive because we were only focusing on physicians, because this was an exercise that was created within the physician ranks. And at a point about 1 year into our program, I was approached by one of the senior vice presidents of the hospital, who's the chief operating officer, and she asked me first if she could come. She said she heard a lot about our program and could she come and sit through one of the workshops. And then she followed up by saying, I think you're on to something. And although we have been doing hard, yeoman's work over the last many years to try and improve the experience of the patients and families we serve, and we have made demonstrated improvement, we haven't had breakthrough improvement. And I was asked to partner with her in thinking about how we might bring the concepts and the approach and some of the tools that we had developed through the Connect program to the greater institution. Now, the good news is, as I alluded to already, a lot of good things were already happening. There are some brilliant people in our organization, just like there are at yours, who are very passionate about the work that they're doing, and we had a number of efforts that were happening so that it didn't mean that we had to create something from de novo. In fact, our first, I think, responsibility and our first action was to bring the many experts from around our organization together so that we could align them around, ideally, a common purpose, a North Star that we could all be pursuing in our daily work. And then very intentionally to try to liberate them, to say, think outside the proverbial box. What is it that you'd like to try? What is it that you feel through your experience and your knowledge that might be groundbreaking? And let's hear it, and let's try it, and let's not be bound to our systems and processes as they have existed historically. We really wanted to be a place of innovation, and we really wanted that to happen on the very front lines. Now, soon after we pulled that oversight group together of our local experts, we had the great opportunity to attend IHI in the fall or winter, I guess, of 2015. And many of you were probably there, and that was the introduction of the concept of the quadruple aim and recognizing that joy in the work place was an essential element if we were going to realize the goals that we were striving for in our areas of population health and cost containment and experience. And so that visit was really important to our group because we were all there, we were all debriefing at the end of every afternoon, and you could tell that we were starting to coalesce around a new approach and a recognition that we had to think about this concept of joy in work if we were going to realize the results that we wanted for our organization. We left, I think, with a recognition that we needed to understand what that means, what the term joy in the work means to our staff. And then we needed to be attentive to it, and we needed to start to be, in real ways, proactive in trying to provide those environments for them to excel and thrive. We left, I think, with a sense that compassionate healthcare means compassion for all, including the folks who are on the front lines and in the support roles, and allowing us to deliver care. Now, the other great circumstance and perfect timing was that we came back to a patient safety conference the following week that was led by the inimitable Dr. Michael Goldberg. Dr. Goldberg is on our staff as the chief of our skeletal dysplasia program. This is work that he's doing in retirement after a very illustrious career at Tufts in Boston as the chairman of their orthopedics department. But in his retirement, he came to Seattle to spend time with his grandchildren, and then just couldn't resist the draw of coming back to Seattle Children's and helping us in our skeletal dysplasia program. But also, Dr. Goldberg is a scholar in residence at the Schwartz Center for Compassionate Care in Boston, and so he brought with him that expertise and that passion. So we came back to this presentation that he made at our patient safety conference that was, I think, challenging to the audience and extremely compelling. The crowd was overflowing, and it's not an exaggeration to say that the energy after his presentation was overflowing. We clearly, as an organization, had our work to do, and we clearly had opportunity to harness the energy of the folks in the room to do that work. We then came back together as a group, and we recognized that we had our work to do and that we needed to do that work in a way that was balancing the needs of the patients and families with the needs of our providers. And we agreed around this sort of tagline that in order to meet or exceed the expectations of the patients and families we serve, we must meet or exceed the expectations of our people. And so that became really a North Star for the work that we were doing. We had to understand, in the words of IHI, what matters to you, what matters to our folks on the front lines. Like most of you at your organizations, we have an overabundance, if you will, of data already available to us. We survey from every angle our staff. And so a small group of our team did a tremendous amount of work to go and access each one of these survey reports and to look at it now through the lens of what does this tell us about the experience of our staff, and how does this inform the work that we're doing, and where are our gaps? Using Cotter's steps in change management, we decided that one of the first steps we could do was to leverage the excitement and the enthusiasm and the passion that we recognized in that auditorium on the date of Dr. Goldberg's presentation. And so we brought together a guiding coalition. And this is just one of we offered a number of opportunities for these groups to come together. And there ultimately, in the original iteration, there were over 100 staff. And our intention was to get their input, to get their buy-in, to get their wisdom, to share the vision that we had for this renewed focus on understanding what mattered to our staff. And then ultimately for them to be the mechanism of spreading the word. This was not an exercise or an endeavor that was going to be able to be achieved by a small group, but this quickly needed to become a movement within our organization. And our guiding coalition has grown. We meet on a monthly basis, and every time we meet, there are more and more people who volunteer the hour to come 1 or 2 times a week to come and participate and engage in these conversations and help shape the work that we were doing. We looked for some quick wins. We put forth some dares to the members of the coalition. We dared them to meet one new person every day, to introduce yourself to one new person every day in the organization. We asked them to go out and, in a not too conspicuous way, just do some observations. We called them elevator observations. Spend some time on the elevators in the hospital and in the hallways, observing the experience of the patients and families as they walk through our hallways, the experience of our staff, and how were we interacting with each other. And I can tell you that these exercises were very informative. I think people went out and through a new lens saw ways where we were missing opportunity to create community amongst our staff, as well as to acknowledge the experience of the patients and families that we were passing in the hallways and seeing in the cafeterias and sharing elevator rides with. We had something that caught on very quickly that we did was we realized that through Outlook you could attach your photo. Each staff member could attach their photo to Outlook, so that now throughout the organization, when you receive an email from someone, it comes with a picture of them. And we thought that was a small but meaningful way to overcome the sense that we had grown so quickly that people didn't know who people were. And it was a way to connect faces to emails. And then, based on the success that we had with the video that we created with the Connect program, we created another video where we very intentionally focused on employees here at the hospital who are not on the front lines, who are not the doctors and the nurses and the therapists who naturally get the recognition for what they contribute to the care that we deliver. But it's a video where we show people in their different areas, and each of them holds up a card that describes what they bring to the organization. And that was very powerful to the staff as we would go out, so that people would start to understand that this work is not just about the doctors and the nurses and the therapists, but it's about each of us in our role, no matter how far removed from the patient, and the contribution that they're making to the care that we deliver. The other thing that we did, and this is something that I thought was, to me, extremely important, and that we went out and did what we called discovery sessions. So over a period of 3 months, there were about a half dozen of us, maybe a little bit more, who were on our original oversight committee for this work. And we went out to every facet of the organization that would have us. We met with them in groups as small as 3 or 4 and as big as 40 to 50. And we had a conversation with them that started simply with, what matters to you? What does a good day look like to you? What is one thing that we could do right now to make for more good days? And what gets in the way of a good day? And we, in doing so, solicited input from over 800 folks across our campus, and we got over 3,000 comments. I think, to me, the biggest lesson, however, in doing this, based on the reception that we received in going out and talking to these groups, was that the feedback that we got and the thousands of comments that we received are important, and they help us to understand the experience of our staff and understand what the opportunities were to help optimize their experience. But what was even more important to me was recognition that it was the going out and asking that was the real therapy, that was the real connection, and that should be something that we should be doing at a much more regular cadence, in a much more intentional way, and frankly, a skill that our leaders needed to refine and incorporate into their regular work, no matter what level they were in the organization. In a way, I've sort of taken to the mantra that the surveys that we do, the surveys that I shared with you earlier, the engagement surveys and others, those surveys, if we're doing our leadership work well, shouldn't be telling us anything that we don't already know. We should be in active communication with our staff on the front line. Having those conversations does a great deal in creating a sense of trust with the staff. And I think it also creates opportunities for us to solve things in a just-do-it manner without having to go through the process of surveys and then developing action plans that seem remote from the staff. Some of the themes that came up are themes that I think would be common to most of you at your organizations. There were issues about inadequate staff. There were certainly issues about overburden and burnout. There were questions about how well we work together as teams. So many of these are overlapping, separating capacity and workload from burden and overburden, and staffing challenges and teamwork and coordination. These are things that I think are common to most organizations, and these are things that in many ways I think are contributing to the experience, both in positive and unfortunately in negative ways, for our folks on the front lines. We, again, as I said, we're on a journey that I think was common to many organizations around the country, if not all. And along the way, we came to realize that we were not immune to this epidemic, if you will, of burnout that was being described in the medical literature and even in the lay press. And so in collaboration with the Schwartz Center, we decided that we needed to understand how pervasive is this issue at our organization, and what can we do in better understanding the challenges that are contributing to burnout amongst our staff, and how can we ideally create an organization and a working culture where our staff are not reaching the extremes times of crisis that I think are part of someone who's burned out, part of their experience. And so we asked the question, the single question that I think many of you may have already been exposed to in our survey. And likewise, we asked a question in our survey in understanding what were priorities for our physicians in the coming years for the CONNECT program. And you can see on the graph on the graph in the right corner that mitigating burnout was our #1 most common strategy that our staff and curriculum that our staff were asking for. So we recognize that we are not immune from the epidemic that has afflicted healthcare across the nation. Now, the good news for us is that we are at a time of exciting change in our organization at Seattle Children's. We just in the last year brought on a new chief executive officer who there's no way to deny is enthusiastic, is innovative in his ideas, and is a genuine believer that the most important resource in our organization are our people. The other thing is that coincident with his arrival, not surprisingly, is that we embarked on a new strategic plan exercise. And in the process of the strategic planning, the CEO made clear that although we want to do innovative, game-changing therapies for immunomodulation and in our neurosciences and in all the different ways that all of our institutions are striving to advance the care for our patients, that all of that was predicated on an understanding of what the team of the future was going to need to be, and how were we going to attract the best, retain the best, and create a culture that the team of the future that Seattle Children's would be an example of what a team of the future should look like. And so I think, in his wisdom, our CEO asked myself and another leader to create a new team for our organization to help chart the course for that team of the future, and we're calling that our experience team. And as you can see from this slide, it's really just an effort to bring together in a cross-functional way all the different areas of the hospital that I referenced earlier and all the great work that was already happening, but in a way that was fully aligned with a shared understanding of what our North Star is, and that was given the license to be innovative and creative. Our first step in that exercise is the question that's across the top of the page, and that's to understand where are we as a culture, and how does our current culture foster, support, and perhaps undermine our organizational values. And so that's the work that we now are doing in 2017 to try to better understand where we are, and then what are our opportunities to create that environment where our staff can show up every day and proudly wear a name tag that I can't get to pop up as I'm building up to this here. It won't advance. Okay, well, the last slide is one that shows a name tag that says, I'm awesome. There it is. Hello, I'm awesome. And we have a lot of work to do. We're not anywhere near completion. I think we have a lot of great ideas, and I think in partnership and collaboration with organizations like the Schwartz Center for Compassionate Care, as well as the many organizations around the country that you are all aware of, as well as your own organizations, I think we're going to be able to meet this challenge.
Thank you so much, Dr. Baden. That was such an interesting description of the journey that you've taken, and I know I learned a lot from it. I'm wondering if we had any questions Andrea can tell us that might have come in during the course of your discussion. Andrea?
Yes, absolutely. Thank you very much, Beth. We do have just a few questions, but before we begin our Q&A session, just a quick reminder to our audience. If you have a question to submit, you may still do so. Just type your question into the questions pane, and we will answer as many as we can in the time remaining. So let's jump into some of our audience questions. Our first question is, what are some of the stories shared in the video regarding satisfaction and dissatisfaction of the doctor's children's experiences?
Well, that's tough. I don't even know where to start. I'll take you through the sequence. The doctors start. There are 5, I believe, doctors, and they start with sharing initially how they learned of their child's illness and the feeling of vulnerability that created in them. One of our providers actually shares what in a way is kind of a cute story of how her daughter had a little laceration in her face, and this is a doctor who specializes in craniofacial abnormalities, and she's a geneticist and a scientist trying to deal with kids who have gross dysmorphology, and yet here she was in the emergency room with her daughter with just a little laceration in the face, and to her it was as important as anything else that was happening in the hospital. And so that recognition that to the patients and families we serve, nothing is small. On the other end of the extreme is one of our providers, one of the orthopedic surgeons, who shares the very moving story of his daughter who was born with one of the metabolic disorders of mucopolysaccharidosis that ultimately led to her death. And she died here in our hospital, and he talked about how challenging that experience was and how important it was for him to have trust in the doctors that led them through that journey and led them to that point where they recognized that there wasn't anything else that they could do for their daughter, and the best way to love her was to let her go, but how they never could have gotten there without the one doctor in particular who came to him and said, you need continuity, I want to be that person. And the listening, the active listening that doctor brought to their interactions that enabled this colleague to develop, and his wife to develop, trust such that they could make such a difficult decision in their daughter's care. And then sprinkled throughout are descriptions of experiences that they've had, good and bad, and even some suggestions for things that can be done that are that may seem minor to us, but to a family who's in a challenging spot are very powerful. To be really honest with you, I'd encourage you, I can show you at the end, we can share with you the name of the video. It's on YouTube, it's available, just look it up, watch it, feel free to use it. Even better, at your own organizations, I'd urge you to create a video from your own staff that can be used in that way, that breaks down those barriers.
Thank you. Thank you. Go ahead, Andrea.
Oh, sorry about that. Great. Thank you so much, Dr. Baden. We actually are getting in quite a few more questions. So let's take a look at our next question from the audience. Dr. Baden, you mentioned debriefing at the end of the day. How is that typically structured?
The briefing at the end of the day? I don't know what you're referring to. I'm sorry.
Oh, is debriefing perhaps, or no?
If you're referring to the workshops that we do debrief after each workshop. As I said, we have a study that we're doing that consists of a pre and post survey. We then sit down and look at the surveys. We are always looking, at the beginning of every workshop, I say to the doctors in the audience, I thank them for indulging us with their time, and I say to them that we don't want to be doing anything to them. We want to be doing something for them. And so I urge them to share their feedback about what resonates about the workshop, what works, what doesn't work, and what would they like to see more of. And then we debrief afterwards on that. And we refine. We've done now, I don't even know how many workshops but we refine each one based on the feedback that we got. So if that's the question, then that's the answer. If it's something different, then please refresh my memory.
Okay. Actually, Harris, I'd like to ask a bit about these workshops that you're still doing. I assume these are the ones that you mentioned at the very get-go that you started for physicians, right?
Absolutely, yes.
Yeah. Now, you're referring to physicians in your discussion, but are these for all staff now at this point? I know they started as being primarily for physicians.
So it started as something from physicians for physicians. To be really honest, in a way, so that physicians actually can do something to try to improve, as a group, to try to improve the culture and the quality of the care. That we weren't always reluctant participants in quality improvement exercises, but because of the attention that we received, we quickly expanded it to include the nurse practitioners in the hospital. So nurse practitioners are going through our workshops. We've done workshops for nutrition, for the dietary services. I've gone and done a presentation to our security staff. To be very honest with you, we have every intention of including everyone and anyone who wants to participate, who comes onto this campus every day to contribute in whatever way they want. The only reason at this point that we haven't opened it up to the world is just because we don't have the capacity to do so. But in the hospital strategic plan over the next 3 years, it is every bit the intention of the organization that we are opening these workshops to staff, no matter what their role. The other thing that we're doing is adapting our workshops when necessary to focus on interactions between staff and staff. So for example, we did a workshop for our pathologists. Our pathologists have very little interaction, direct contact with the patients and families we serve, but they have a great deal of interaction with their colleagues in the organization. And so we reconfigured, the principles are the same, and we reconfigured the workshop in a way that was meaningful and useful to them. Likewise, we're getting ready to do a workshop for our senior nursing leadership. The chief nursing officer has asked us to do a workshop for her direct reports, and we're starting to think about how do leaders interact with each other as well as those who report to them, and what are the elements of those interactions that are common to the interactions in any relationship, including those with patients and families. And so our influence and our scope creep is real, but we have to do it in a way that we have the capacity to do.
Mm-hmm. So these are unit or department-based workshops?
Yeah, so
ideally, as requested, yeah.
Yeah, ideally, Beth, they are for a couple of reasons. One, it's easier to get a group of doctors from one area to set aside time when their chief says we're setting aside time to do this. And I will say that we're very accommodating. So our workshops are 4 hours. We have started workshops, for example, for orthopedic surgery at 6 o'clock in the morning. So that they could be out and into the clinics and the operating rooms by 10 in the morning. Likewise with radiology, we've done similar workshops. But yes, we ideally try to do them as a group. It also enables for the role playing that we do to be common scenarios common to those specialties. Because to be honest with you, probably the greatest learning that the doctors get out of these workshops is from the comments that their colleagues make. Oh, here's how I do this, and then others saying, oh, I could do that, and so forth. So that's very powerful. In an effort to catch everyone, we do have some catch-all workshops where anyone can come by, could come in who perhaps missed when their group was when their group was meeting, or is just ahead of the curve compared to the rest of their group, and so they want to get involved.
Mm-hmm. Mm-hmm. Okay, I know we have more questions. I have like a million questions, but I'm going to defer to the audience. Go ahead, Andrea.
Okay. Thank you, Beth. All right, great. We do have some more questions from the audience. Another question is, I'm interested to know how Seattle Children's has followed up with the staff feedback on desired changes. How do you communicate with the staff who want changes that are difficult to address?
Well, that's a really great question, and the cop-out answer is that we're just starting that process. We just, this work, these discovery sessions that we did, where we went out and solicited this feedback. This all just happened in the last couple of months of 2016. The experienced team that I described was just formalized at the beginning of this year. We actually just had our first retreat last Friday, and so we're just getting started. I guess I'll have to check back with you in a year. But we recognize that, and one of our guiding principles is that that is an essential element. It would be counterproductive, frankly, for us to go out and solicit this feedback and then not come back and close the loop and say, here's what we've heard, and here's what we've heard from you, and here are the solutions that we are starting to think about. It also gets at the point that we are very intentionally not intending to go out and provide solutions. Rather, we're hoping to create an environment where solutions can be local. And that's a culture change for our organization. We have traditionally been an extremely hierarchical institution. I sometimes joke that, you can't order pencils in this organization unless the senior vice presidents decide that we're ordering pencils this week. And fortunately, our CEO has recognized that immediately, and it's one of his mandates is that we need to flip the culture here so that our senior leadership recognizes that they are in here in support of our staff, not to be reported to by our staff, and that the folks who know what's happening on the front line are the folks who will have the best solutions, and we need to create a culture where they are empowered to do so.
Absolutely. Thank you very much, Dr. Baden. Looks like there's time for one more question. Our final question for today's webinar is, can you talk a little bit about the workshop content?
Sure. So the workshops basically are broken into two different stages. Because we are so committed to this idea of not thrusting things upon our staff, but rather leading them through conversation in a way that helps them create the curriculum, if we will. We start the workshop by an exploration of a better understanding of what is it that our patients and families might be feeling. The video is very powerful in triggering that conversation. I like to ask 4 questions. My first question of the audience in this regard is, why are our patients and their families here? And the simple answer is they're here because their child is sick or may be sick or needs a procedure. The second question is, how do you think they feel? And the answers are numerous, but ultimately they coalesce around the idea that they feel vulnerable and they feel possibly scared. The third question is, what do you think they want? And so that's when we start to think about what are the things that the families want? Well, they want good communication. They want to be listened to. They want, an understanding of what's happening next. They want clarity. In as many ways as we can demystify the experience, those are the things that are usually shared from the audience. And then the last question is, so what do you want to give them? And that you is you as an individual, and that you is the collective you. What do we want to give to the patients and families? So we spend a lot of time trying to get into that space. And then we likewise spend a lot of time talking about, why are you in healthcare? What motivates you? What are the things that fill you up? And where are the commonalities between those and what patients and families are looking for? And fortunately, they're right there, right? They're about relationship. They're about the human connection. And so once we've gotten them to that point where they see what's in it for them and they see what's in it for the patients and families, then we turn the latter part of the workshop into, let's practice some common scenarios that you encounter in your everyday, and how can you bring some of those qualities that we just talked about more consistently into your interactions with the patients and families. in your own authentic voice. We don't ask them to use a mnemonic. We don't encourage them to, follow a script in any way. We try to introduce the principles. We try to get them to take root in their hearts and minds, and then we try to help them find their own authentic voice. And then we practice. At the beginning of the workshops, we tell the doctors there's going to be role playing at the end, and there's a collective groan. And then in our feedback, it's one of the most common things that people ask for more of. It's worthwhile element of the workshop.
Absolutely. Wonderful. Thank you very much, Dr. Baden.
Sure.
It looks like that wraps up our Q&A session for today. Beth, any final thoughts to share with our participants?
Well, I just want to thank you, Harris, for a superb webinar, and I know that I'm taking a lot of ideas home. I'm sure our listeners are as well. And again, we want to remind everybody to check out the webinar. It'll be up on the website. Also, check our webinar for our notices about our inaugural Compassion in Action Healthcare Conference. Take a look at the agenda. It's very exciting. You'll see Dr. Baden on the agenda. Register, sign up. We hope to see you in Boston.
Thank you.
Great. Thank you very much. I would again like to thank Dr. Baden for sharing his insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope you enjoyed the first in a series of webinars focused on organizational cultures of compassion. These topics and more will be covered at our inaugural Compassion in Action Healthcare Conference to be held June 25th through the 27th, 2017 in Boston. To register or learn more about the conference, please visit compassioninaction.conference.org. We also hope that you will join us for upcoming programs in the Compassion in Action webinar series. Please visit our website to see our upcoming programming and learn more about the Schwartz Center for Compassionate Healthcare and our membership program. We know you are busy, but we would very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, as we value your input. Thank you, and have a great day.